In the days to come, various topics will be covered. And today, we are having two eminent speakers. One from AIMS Patna, that is Dr. Irene Mathews. Basically, she is from Kerala, but she did her post-graduation in JIPMA and did her fellowship in pediatric dermatology there itself. And then joined to Kottayam Medical College. Now she is working in AIMS Patna. And she will be very enthusiastic about pediatric dermatology. And now she will be talking about atypical manifestations of atopic dermatitis. Now, we all know that atopic dermatitis with the classical presentation from the infancy to the adulthood. But there are a number of atypical presentation which may be mimicking or may be mistaken for various other dermatological conditions. So in order to differentiate this from various other dermatological conditions, we should know what are the typical manifestations. So Dr. Irene Mathews will be discussing that in detail. And over to you, Irene.
Thank you for the kind introduction. I hope my screen is visible and I'm audible.
Yes.
Naveen, sir?
Yes.
Thank you. I'll be speaking on the atypical manifestations of atopic dermatitis. So as again, this is quite vast and topic is quite short. I'll focus on the practice points which are most important for budding postgraduates and some points which we may not consider in management, especially triggers which are atypical. So I have no conflicts of interest, and I'd like to thank East West Pharma for including me in the Glow webinar series, and definitely Crichton sir, who's one of the stalwarts of pediatric dermatology for a very long time now, since the beginning of my medical career. So I'll just start with a brief overview of what is typical or classical in atopic dermatitis. Like we all know, we have it is classified based on the age of onset. Infantile, which is under 2 years, where we have the typical lesions over the convexities of the cheeks and the extensors of the body. There are some other extra points which we'll discuss in infantile AD. Then in childhood AD, we have the lesions shift off from the extensors to predominantly the flexors, that is the anterior cubital fossa, popliteal fossa, but the axilla and the groin will be spared. Neck is involved, but associated with that, instead of the cheeks, we have maybe eyelids and other periorificial areas. Then we have about 12 years adolescent AD, again, which is predominantly flexural, but as the people age from 12 to 18 and above, it mostly the flexural pattern also tends to disappear, and we get like hand and foot dermatitis, localized forms of dermatitis in different parts of the body, like nipple eczema, eyelid eczema, and all that. So this is what is classical, which is known for a very long time. But what is recently being described is the onset of atopic dermatitis that is happening in adulthood and also above 60 years of age. So previously, we assumed that any AD that you see in an adult above 18 had actually started as either infantile, childhood, or adolescent, and it is just continuing, just a change in the pattern. But I think the first proper description of adult onset AD was in 2000. So, but even before that, there are plenty of case reports from Asia which shows that atopic dermatitis do occur in adults, and there was no similar history that is in the past. So onset is definitely adult. It has its own morphological and other clinical features which probably require a different diagnostic criteria, but we have so far, because it's a recent entity, we have some clinical clues. We have to exclude other conditions, but we don't have distinct criteria for that. The same goes for elderly or senile onset AD, which again looks quite different and probably needs a set of different criteria. So I'll just go briefly through adult onset atopic dermatitis before we go into the atypical forms in children. So first one would be adult onset atopic dermatitis has eczema with lichenification. That's a classical finding, which is affecting the flexures, predominantly the cubital fossa and the popliteal fossa. And associated with that, there can be head and neck dermatitis. So this one is not quite difficult to diagnose, except for the fact that it's starting quite late. And most of the studies have shown that the onset of adult onset atopic dermatitis is dorsum of the hands in females and eyelids in males. And I think our postgraduates will be aware that when we see symmetrical eczema to the dorsum of the hands, we always have a clinical clue that this is an endogenous, possibly an atopic.
Um, I think the connection is disrupted.
Sir, madam connection is disrupted. 1 second.
This caller and
Yeah, sir. I'm calling her. Call.
yeah.
Sir, unable to connect, ma'am. I called. Ma'am, unable to connect.
Hello, sir. I think my network changed a bit. 1 minute, sir. I'll just attend a call from Mr. Naveen.
Yes, ma'am. No
I
problem.
think he has
I make it
disabled.
forward. Yes, yes.
Yeah.
Now, given 1 second, ma'am.
Sir, I'm just not able to share because I
Ma'am, now
exited
I've
for a
given,
bit.
ma'am. Yes, now you
Sure.
can share.
Thank you. Yeah. Sorry
yeah,
for the
yeah.
interruption. So just as I was saying, senile onset atopic dermatitis manifests as non-specific erythroderma. So you have plenty of other causes like
Dr. Irene, can you go back?
yes, sir. I think I missed. Adult onset atopy, sir.
Yeah.
Yeah. So first thing would be, before going into details of atypical features in children, briefly about adult.
You are not audible now.
Ma'am, you are on the line, ma'am, but audible. You are not audible, ma'am. Uh,
Dr. Rashmi? Rashmi?
Sir?
Can you start? Because there is some problem in the.
Yes, sir. Yes, sir.
Yeah.
You can start.
Sorry for the interruption. Dr. Irene could not get connected. So now Dr. Rashmi Philip will be talking about the severity indices in atopic dermatitis. Dr. Rashmi Philip is assistant professor of dermatology in Amala Institute of Medical Sciences. She did her post-graduation in the same institute, and she has joined the department and now continuing. She is very much interested in atopic dermatitis, and in fact, she is one of the pioneer pediatric dermatologists in Kerala. So over to you, Rashmi.
A very good morning to all. Thank you very much, Crichton, sir, for those wonderful words. Actually, sir, those wonderful words have have indeed brought so much. I don't know if I'm worth all those words, actually. Thank you, indeed. Thank you. Anyway, thank you, sir, for having considered me for this topic today, severity indices in atopic dermatitis. And I would also extend my gratitude to the East-West Pharma for having organized this forum. And over to the topic, severity indices in atopic dermatitis. And now for a postgraduate, this topic becomes important in three areas. One, for your thesis. Two, for answering a question when you get a question in your paper. And three, in routine clinical practice. So severity indices in atopic dermatitis. As we all know, atopic dermatitis is a chronic pruritic relapsing dermatosis, and it affects adults and more commonly so children with a prevalence of 15 to 30% worldwide. It presents with varying morphological patterns. In certain individuals, it presents with oozy weeping lesions, in some with the crusted lesions, and in many with lichenification. And in the follow-up of these people with such a fluctuating disease, a more informative way of recording than the patient seems better or worse is very necessary. And here comes the importance of assessing the severity of the disease. Now, what is the need to score the severity of atopic dermatitis? The need comes, one, in clinical trials, and two, in clinical practice. In clinical trials, the need is mainly in therapeutic trials to assess the efficacy of the drug in question. And second, in clinical practice, it is to assess the prognosis of the disease. That is, more higher the severity score, worse the prognosis of the disease. And it also helps the physician to initiate certain therapeutic modalities of of treatment. And also it helps in assessing the therapeutic response during follow-up. But sadly, in atopic dermatitis, there is no gold standard today that exists to assess the severity of atopic dermatitis. And also there is no laboratory markers available. So we have to restrict ourselves to certain clinical activities, such as answering questionnaires, which are now considered consistent and reliable. So when these questionnaires are answered by physician, nurses, or relatives, they are termed as interviewer-administered questionnaires. And when they are answered by the patient themselves, they are termed as self-administered questionnaires or patient-reported outcome measures. Measurement of visible clinical signs or objective signs are done by the physician themselves. And measurement of symptoms and quality of life or subjective symptoms can be done by the patient themselves, or it can be done by the physicians. Now, what is the definition of a scoring system or an index? These scoring systems or these questionnaires are instruments that help in the measurement of the objective signs and subjective symptoms, which in turn help in the assessment of various parameters of the disease, which helps in the assessment the disease has on the individual. Now, better the instrument, better the measurement. That is, higher the quality of the instrument, more robust and trustworthy is the measurement. These instruments are the scoring system and the indices, and what they measure are the objective sign and the subjective symptoms. These are also called as the core outcome set, or the COS. Now from here starts the long and never-ending story of the severity indices. Now, the consensus-based standard for the selection of the health measurement instrument, or the COSMIN initiative, is a group of researchers which with a background in epidemiology, medicine, research, and healthcare, who set out to identify ideal instrument in healthcare. And they stated that an ideal instrument should have these 5 characteristics. That is validity, reliability, responsiveness, feasibility, and interpretability. According to them, an instrument is said to have an adequate validity if it measures what it is supposed to measure. For example, if an instrument is supposed to measure 4 objective signs, such as erythema, edema, excoriation, and lichenification, it should measure just these 4 signs and not, in addition to it, measure oozing and scaling. Reliability is the precision with which an instrument does its measurement. There are 2 kinds of reliability: inter-rater reliability and intra-rater reliability. Now, inter-rater reliability is when 2 dermatologists using the same scoring index under standard conditions generate 2 different measurements. That instrument is said to have low inter-rater reliability. And intra-rater reliability is that if the same dermatologist using the same index at 2 different points obtains 2 values in a patient with same severity, then that index is said to have low intra-rater reliability. Responsiveness is the ability of the instrument to detect small change of the disease over time. Feasibility is the ease with which an instrument can be applied on a target population. Interpretability is the degree to which a qualitative meaning can be assigned to the measure of an instrument. I hope it's a little confusing, but as you go ahead, you'll understand. Now, thus, COSMIN stated that a scoring system should have adequate validity, should be relevant to the target population, and should be comprehensive, should not be all that complicated. Okay, with all this in mind, they set out to identify an ideal instrument. And with a large number of drugs for the treatment of atopic dermatitis and an explosion of research, there came about a large number of instruments for the measurement of the severity of atopic dermatitis. The first one was in 1989, the Rajka and the Lagland, and the simple scoring system. After this, various named and unnamed scoring system came up. A systemic review which was done in 2000 revealed that there were around 62 scoring systems for measurement of objective signs and 28 for the measurement of quality of life. But sadly, none of them had adequate validity, reliability, or responsiveness. They did not fulfill any of those criteria that was put forward by Cosman. And further, in 2013, a study was done which showed that only 16 of them were having sufficient validity. And in 2016, a randomized control trial was done, which showed that the most commonly used severity indices were SCORAD, Visual Analog Scale for Pruritus, Investigators Global Assessment, and EASI. And the items or domains that were commonly measured in these scoring systems were these that were shown here. So these 16 scoring systems, which were used commonly, which were showing to be having sufficient validity, they did not measure the common items. They differed in their items and they were of poor reliability. Now, this was a significant threat to evidence-based medicine because the clinical decisions were made from the data which were available from the clinical trial. And hence, in 2008, a very noble and novel initiative came up, the Harmonizing Outcome Measure for Eczema or HOME. Now, this was an initiative which was an evidence-driven research initiative that aims to standardize and validate a set of instruments for atopic dermatitis and increase the quality of research in atopic dermatitis. Now, this HOME is a global initiative which was founded by Professor Hywell Williams and Joshin Smith, and they work to bring together the eczema research community and to standardize outcome measure instruments by agreeing on a core outcome set. The core outcome set is the minimum that should be measured in all clinical trials. Now, the highlight of the HOME is that it includes different members from all across the globe, and it includes not only health professionals, but also patients, parents and caregivers, and of course, journal editors and pharmaceutical industry. Now, the HOME initiative, it began with a Delphi exercise. This Delphi exercise is online meeting of 46 members, 46 experts rather, from all across the world. And they came to a conclusion on 4 outcome sets that should be measured in all clinical trials and clinical practice. And from then on, the members of HOME initiative, they met every year, starting in 2010. And every year, they identified an instrument that could be used to measure the SCORE outcome set. And recommendations were laid forth for clinical trials. And they are working on recommendations for clinical practice. So with the Delphi exercise and a systemic review of the already existing instruments, they put forward the core outcome set, namely the clinician-reported signs, the patient-reported symptoms, the quality of life, and the long-term control. And these are the recommendations for the clinical trials, that these are the instruments that should be used for measuring the core outcome set in the clinical trials. That is, the Eczema Area Severity Index should be used for measurement of clinical signs in a clinical trial. And the inpatient reported symptoms, the patient-oriented eczema measure or the numerical rating scale 11 should be used. For quality of life index, the Dermatology Life Quality Index In case of children, the Children's Dermatology Life Quality Index, and in case of infants, the Infants Dermatology Life Quality Index should be used. For long-term control of disease, the recap or the dermatology or the adults dermatitis control tool can be used. So this is a pictorial reference of the 4 core outcome set and the instruments that should be used for measurement of these core outcome set in the case of clinical trial. So let's have a look at these instruments that should be used in the clinical trial. Now, before they embarked on EASI for the clinical trial, the review of literature showed that the most commonly used instruments in case of clinical science were EASI, SCORAD, Investigators Global Assessment, 6-area, 6-sign atopic dermatitis, and 3-item severity index. But the last 3 severity indices lost out on the bet because they were not properly validated, and EASI won the battle. EASI and SCORAD had a battle between each other, but EASI won over SCORAD. Let's see why. Now, Eczema Area Severity Index was developed by modification of PASI scoring system. Eczema Area Severity Index, it incorporates the extent of involvement of eczema on the body, along with intensity of lesional skin of objective signs, mainly erythema, edema, excoriation, and lignification into a single composite score. It does not take into consideration the subjective symptom of the patient. This scoring system has good validity, reliability, and responsiveness. So when you calculate the EASI score of a patient, you divide the body into 4 areas, namely the head, neck, the trunk, the upper limb, and the lower limb. And in each area, you have to calculate the percentage of surface area involved with eczema, and also the severity of the 4 clinical signs, which are scored on a scale of 0 to 3, 0 being none and 3 being severe. The pictorial reference, and this score is noted on a scoreboard. This is the pictorial reference for erythema. This is for edema, this for excoriation, and this for lignification. Where for calculation of the percentage of body surface area of each region is considered as 100% and further divided into smaller parts. That is the face 33, scalp 33%, the front of the neck 17%, and the back of the neck 17%. Similarly, the trunk is divided, the upper extremities, lower extremities is divided. For example, in this gentleman, for calculating the percentage of eczema involved on the head and neck, consider his head and neck involvement. The cheek is spared, so approximately he's got 25% involvement on the head and neck. So his area score has to be calculated then, which turns out to be 2. For calculating the EASI score, the EASI of each region is calculated separately. That is, the intensity score has to be summed up, which is then multiplied by the area score and then multiplied by a constant. Is it visible?
Yes, doctor, visible, doctor.
It is visible. It is visible.
Okay. Is multiplied by a constant, and then you get the EASI of that particular region. Similarly, the EASI of each region is calculated separately and is summed up to get the final EASI score. For children under 8 years, a similar method is followed, but the constant with which you multiply is different. After the final EASI score is obtained, atopic dermatitis can be then differentiated into mild, moderate, and severe by the EASI score interpreter, which is given below. Though it seems a little difficult and complicated, a user guide, training video, and a EASI app are all available on the website for home. Each time the patient visits the outpatient department, EASI should be calculated separately. And this index has got an excellent reliability when compared to other instruments. Now, the SCORAD index, or Scoring Atopic Dermatitis Index, was developed by the European Task Force much earlier, and this instrument is more commonly used when compared to EASI. And this instrument, it incorporates the intensity, extent of body surface area involvement, along with the subjective symptoms of the patient. And it includes along with the other 4 objective symptoms, it includes oozing and xerosis on a representative body site, and it also scores the lesional intensity on a scale of 0 to 3, just like EASI. The body surface area is calculated by using the rule of 9 and Pharma method, which is different from EASI. Subjective symptoms that are included here are pruritus and sleep loss by using the visual analog scale. This scoring system has got good validity and responsiveness, but reliability is unclear. The SCORAD training is available on this link here, given here, and a SCORAD app is also available. Now, this formula for SCORAD is given here. A stands for body surface, B stands for lesional intensity, and C is the subjective symptoms. The maximum SCORAD score is 103, and this is the SCORAD score range. The problem with SCORAD score is that if the patient has got less body surface area involvement and lesional intensity is less, but he has got high pruritus and sleep deprivation, the SCORAD score goes up. So the European Task Force, they scraped out the subjective symptoms, and what we have now is an objective SCORAD with the above formula. So the maximum objective SCORAD score is 83 with a bonus of 10 points added to it if the patient has got involvement of the face and the hand. This is the SCORAD scoring sheet. Now, the patient-oriented scoring of atopic dermatitis is a self-assessment index. The app for this PO SCORAD is available on Google Play, which can be scored by the patient themselves. Questionnaires, which are a pictorial form, is also available, which can be self-assessed by the patient and then scored by the doctor. This is a less time-consuming index. And studies have shown that the PO SCORAD scores correlate linearly with the original SCORAD index. This is the PO SCORAD form. Now, at the third home meeting, a consensus was reached that all clinical signs in all severity indices should include both intensity and extent of atopic dermatitis. And intensity should include lichenification, excoriation, and edema and erythema. So EASI was found to have better validity when compared to objective SCORAD, and hence EASI won the battle over objective SCORAD. Final consensus meeting chose EASI as a core outcome measure instrument. Advantage of EASI was that it had more precision, it measured the clinical signs on multiple sites, and it gave equal weightage to extent of lesion and intensity. Now, global measurement of atopic dermatitis, they are quick and simple snapshots of disease activity. These are another type of severity measure instrument. They measure the disease in an overall form, like mild, moderate, clear, almost clear, in a gestalt approach. 2 forms of global measurement instruments are investigators' global assessment and physicians' global assessment. They are influenced by the clinician experience and doctor-patient relationship. They are commonly used as a standard by which other measurements are validated, but yet there are no explicit scoring instructions for these measurements available. A study revealed that 30% of randomized controlled trials used one form of the investigators' global assessment as outcome measures, but still they are not formally validated. 23 different types of unique scoring systems are present, but they vary in size, contents, and instructions. They only take into consideration the signs of the disease, but extent of involvement of eczema with the body are not assessed. There are various point scales, 3-point, 5-point, 4-point, but the 6-point scales are the ones which are most commonly used. This is a 6-point scale investigators global assessment. These are the different types of investigators global assessments which are present. These global assessments are most commonly used in the American states. Europeans usually do not favor them. Given the fact that they are used commonly, an urgent need for validation is necessary with the aim of standardization. Until further research, it cannot be recommended which global instrument is to be used. The US FDA recommends its use in therapeutic trials for reasons which are unknown. Validated investigators global assessment is a type of investigators global assessment which is out recently in 2022. But this awaits validation by the home initiative. It has not yet been validated by the home initiative. Now, extent of disease is another tool, the BSA, which is used as an severity indicator. But it is used very popularly either alone or as a part of other indices like SCORAD and EASI. It's very easy to use and it's being used widely. There are different methods. Rule of 9 and Pharma methods are the popular techniques, but there is no standardization. It is not an ideal instrument to be used in atopic dermatitis because of these various reasons, because of the indistinct lesional margin of atopic dermatitis, the three-dimensional shape of human body, and moreover, when the areas like the face and the hand are involved, people with atopic dermatitis tend to have a more severe disease than when there is a mild disease involving larger part of the body. So this is not a very ideal method. The BSA is not a very ideal method to be used to assess the severity of disease in atopic dermatitis. Now let's have a look at the instruments or indices to be used for measuring patient symptoms. Now it was reported by home or recommended by home rather that for measurement of the clinical symptoms, irritated skin, redness, dryness, sleep loss, and itch be used as the core outcome set. 18 instruments were identified, but only these 5 were considered as candidate instruments. But out of these 5, patient-oriented eczema measure and numerical rating scale for itch were finally chosen as ideal instruments for measurement of clinical symptoms, and the rest 3 lost for various reasons. Now, patient-oriented eczema measure is a self-reported validated questionnaire, which is available in paper and electronic form. It's available in various translations, and the English version is a copyright of University of Nottingham. This questionnaire is available on the Nottingham website, and this is a very questionnaire which can be filled very easily. It has 7 questions, 5 responses, and each response is scored from 0 to 4. Its score range is from 0 to 28, and higher the score, more severe the disease. There are 3 types, one for the parent, one as a proxy, and one for the caretaker. This is the questionnaire. The next indice that can be used for the clinical subjective symptoms is the peak pruritus numerical rating scale. This was developed to assess the severity of itch in drug trials for patients with moderate to severe itch. This is designed to assess the worst itch over the last 24 hours, and it is a single self-reported item. And it is a popular choice among patients because it's very simple to answer. It is not validated for younger children, and it cannot be used as a proxy measure. This is its format, and this is how it is rated. Now, these are the instruments for the quality of life. Now, quality of life indices, it measures the impact the disease has and the treatment has on the physical, psychological, and the social functioning of the patient. It can be a self-administered questionnaire or a proxy questionnaire. There are many indices available. These are the commonly used ones in atopic dermatitis, but at the Home 7 meeting, it was recommended that these three questionnaires be used for clinical trials because they have good validity, but new instruments are currently being developed and they will soon be used in due course of time. Now, the Dermatology Life Quality Index was the first dermatology-specific questionnaire to be developed. It can be used in other diseases as well. It's commonly used in atopic dermatitis. It's available in various languages, and it is used in patients above 16 years of age. The questionnaire is available in the Cardiff University website. There is also, e-version is also available, which is validated. Both of them are validated. It consists of 10 questions with 4 responses, and the response pertains to the impact the disease has on the quality of life of the patients over the last 1 week. And each question is scored on a 4-point Likert scale. The higher the score, the more impaired the quality of life of the patient. This is the score. This is the questionnaire. Children's Dermatology Life Quality Index is very much similar to the previous Dermatology Life Quality Index. There are 2 types, a cartoon version and a non-cartoon version. The non-cartoon version is used for, the cartoon version is used for children from 4 to 11, and the non-cartoon version is used for children from 11 to 16. It is also available on the Cardiff University website, and the scoring and the Likert scale, everything is similar to the Dermatology Life Quality Index. This is the cartoon. The Infants Dermatitis Quality of Life Index is designed for use in infants with atopic dermatitis below the age of 4 years. Self-explanatory questionnaire, it is completed proxy by the parents or the caretakers. Again, it is available on the Cardiff Life University website, and it's very much similar to the previous 2 indices. Now, for measuring the long-term effect of the follow-up of the disease, long-term control, you have 2 types of indices, the Atopic Dermatitis Control Tool and the RECAP. Both of them are new instruments, and it's not possible to select between them because both of them show good measurement properties. So either of them can be used for the time being till further studies. The RECAP is a 7-item questionnaire. There are 2 versions, a self-reported one for adults or older children, and a caregiver or a parent version for younger children. You can download this on mobile devices using the app My Eczema Tracker, and it can be completed electronically, and the score can be automatically calculated, and the eczema control can be tracked over weeks and months. A higher score indicates a lower atopic dermatitis control. Decrease of 5 points shows that there is a good eczema control, and an increase of 5 points shows that there's a worsening of atopic dermatitis. This is the RECAP. Atopic dermatitis control tool is again a easily scored tool. You have 2, one for adults, which is validated, and another for children, which is yet waiting validation. Now, these are all the tools that are mentioned for trials, and they seem very exhaustive and difficult. So what are the recommendations for clinical practice? Now, for an outcome tool or for an index to be used in clinical practice, it should have good validity. But the main point is that it should require minimum training, and it should be time efficient. In a practice like what we have in India, where we see around 90 to probably some people see even 100 patients. These kind of tools are not really practical. So available instrument to you assess the objective signs are, which I've already mentioned, are time consuming and user dependent. So these tools are not acceptable, are not adequate for routine clinical practice. So recommendations are pending for objective signs. The present recommendations for objective signs are pending till further studies. But so what has to be done? You can use the home initiative for guidance, or you can use the global assessment tool, but validity is lacking. This is not a home recommendation, but then they do say that the US still say that you can use the global assessment tool, or you can use the home initiative as guidance. For the patient-reported symptoms, the PO SCORAD, POEM, or NRS can be used. Long-term control recap or the atopic dermatitis control tool can be used. The other areas, the work is still in progress. Are there any serum markers for measuring disease activity? Yes, these two serum markers, the TARC and the CTACK, have found to their levels have found to correlate with the serum activity, but still studies have to be done to ascertain their role in to ascertain their further role. So the conclusion is that it must be acknowledged that there is a lack of permanency of any core outcome set. If this is what the home initiative has said, if another international group comes with a set of rival core outcome set, these recommendations are bound to change. And if there is a difficulty in using these instruments, an instrument of our choice may be used, and hence the search of an ideal instrument still continues. Thank you.
It's wonderful, Rashmi. Even though it is quite confusing, we have a little bit of idea about what is the severity indices, and all the postgraduate must do some homework on that. Then only they will understand what Dr. Rashmi has told. And I mean, you can use your own or choose your own severity index, or you can use the various out of these various indices, your choice. And you practice it, then only you will be in a position to do it. And one fine morning, if you are taking an index and want to practice it, is not possible. So from now onwards, you start when you see atopic dermatitis, whether it is in the infant or in the child or in the adult, you think of the severity index and do it regularly, so that when you pass out from the from the department, you can use the indices confidently, and you can classify atopic dermatitis and give better care for the patients. So thank you, Dr. Rashmi, and thank you very much.
Yes, sir. Sir, I would just like to tell the postgraduate, if they go into this home for eczema website, they will get a better clarity. It's given very beautifully, everything there. Okay. I mean, just for reference, things are, more clear there on, all these, how to calculate, especially for their thesis and all that. It will be helpful.
Now, for postgraduates, if you have any doubt, you can contact Dr. Rashmi through EASI Pharma. So they will contact Dr. Rashmi for guidance, and you can have a better idea if you need a guidance. Thank you, Dr. Rashmi.
Okay, thank you, sir. Thank you so much.
Now, this time we are not having the queues. We will directly go to Dr. Irene.
Thank you, sir. I think it's been stable for the past half an hour for me also.
Yeah, okay.
It is visible, sir?
Yeah, it is visible.
Just make it full screen. So I think we reached the senile onset AD last time. So we have finished everything that is not to deal with children, and the rest of my presentation is mostly to do with atypical things in children that postgraduates may have difficulty with. So then next thing that I need to talk about is head and neck dermatitis. So this is something that I've been mentioning for the past few slides. It can happen in adult onset AD, where it is a part of more extensive lesions, like there'll be flexural dermatitis and all that. So it is not difficult to diagnose as such as atopic dermatitis. But in adolescent onset atopy, this can start as an isolated head and neck dermatitis without eczema elsewhere. So the diagnosis of AD may not be that clear. So especially in adolescent onset head and neck dermatitis, you can have a diagnosis of airborne contact dermatitis because this involves eyelids, the flexures of the head and neck, the V area, upper chest and all that. Allergic contact dermatitis, especially to topicals which are applied to the head and neck, and also seborrheic dermatitis, which is again this particular area. So this is actually an image of adult onset head and neck dermatitis, where you can see that in the first picture, you can see the facial lesions, neck lesions, upper chest lesions, and also the scalp extension with accentuation of the lips and the periorificial areas. But in the second image, you can see that there is in the cubital fossa, there is typical flexural dermatitis. So this is head and neck dermatitis occurring in the setting of a typical adult onset AD. So that is not difficult, but if only have the upper half of the body, that there the diagnosis of AD might become difficult. So this is for postgraduates to ease of remembering. This head and neck dermatitis is typically referred to as the beekeeper dermatitis. So that just means that the distribution is something covered by a beekeeper's hat and wig. So scalp, head, neck, and upper body. So why should we identify this as atopic dermatitis? You give emollients, you give topical steroids, even if it is allergen contact and all, because management is significantly different. So once you diagnose this as head and neck in dermatitis type of AD, we know that it is related to hypersensitivity to malassezia. So here it has been multiple studies have proven that there is specific IgE as well as positive prick test to malassezia, and it responds dramatically to itraconazole, even though into other treatments it may be relatively treatment resistant. And unusual point is that many cases of AD who have been treated with dupilumab, even though they had a typical picture initially, after treating with dupilumab, everything else is resolved, but they started to get this head and neck kind of pattern. So exactly, we don't know what has happened. Maybe there is a change in the cytokine profile, but still it again responds to topical assault. So that's a very interesting observation, which might help us to identify why we get this pattern. So everything else from here is exclusively about children. So this is a huge list for postgraduates for how AD in children can be atypical. On the left side, we have the ways in which the morphology is atypical. And on the other side, we have ways in which the site can be atypical. So if we have the typical pattern like flexural or extensor in infants, AD is quite clear. But sometimes we have localized periorificial eczema, is an eyelid, lip licking, or cheilitis, or you have a hand eczema even in children, which is not that common but still does occur, or fingertip eczema, or we have different types of feet eczema, which may involve the sole or the dorsum. And in older children, we can even get nipple eczema. And infants with AD have more tendency for irritant diaper dermatitis also. And another thing is that, especially in infants or younger children with severe AD, when head and neck is involved, they can get a marginal alopecia. So if AD is severe and you are getting alopecia, especially in an infant, a proactive postgraduate would usually jump to conclusions of Netherton syndrome or metabolic syndrome with eczema where there is hair loss. But it might be reassuring to know that even though there is hair loss, in many cases, it is still just AD. So nummular dermatitis and all is common in older people, but even in younger children, even as a part of typical AD or isolated, you can get nummular dermatitis. And atopic prurigo is most commonly prurigo simplex or even the nodularis type. And then there are some more things which we'll address in the coming slides. So just to remind you that there are many things which are classified as atypical by the Western literature. But as far as we are concerned, or the postgraduate working in India or especially South India is concerned, many of these things are typical for us. They are more common, but for Western literature, this is like the Asian or the Indian or the black skin type. So there is something that we used to call frictional lichenoid dermatitis, and now it has been reclassified. So this is something I think every postgraduate would have seen. This is a young school-going kid who comes with elbow and knee lesions, grouped follicular papules, not coalescing, but they are slightly scaly or hyperkeratotic. This is there in the elbows and knees. Sometimes there will be some dryness or some other atopic markers, but no pruritus. It's usually asymptomatic. It's a cosmetic issue. Parents are worried because it keeps recurring. And it is elbows and knees. So earlier we used to call this thing as frictional lichenoid dermatitis, and we thought it was a variant of atopy. And emollients and topical steroids do work in this condition. And now there's been a very interesting studies, including one from India, where they have correlated the occurrence of this dermatitis with the UV index from meteorological data. So every month they looked at the UV index and the occurrence of this lesion. And they finally, because of the close correlation, they classified it as a photodermatosis. So what used to be something we called as a minor variant of atopy is now mostly reclassified as a photodermatitis. So, and in any case, it's a self-limited benign disorder. It's just a cosmetic issue, keeps on recurring, topical steroids, emollients, and probably we can add sun protection to it if it is suitable for the child's lifestyle. But the common things that we see in children in India is the two types. One is called the lichenoid atopic dermatitis and the follicular atopic dermatitis. So if you look at literature, you will see this in Indian reports, you will see this in black skin and all kinds of brown skin. But this is not very typical for Caucasian skin is what we mean. But in India, in your OPD, this is the commonest thing that you'll be seeing. So in lichenoid AD, you can have, there are some reports which say that there are lesions like lichen planus, violaceous papules, which may be slightly scaly. But the common one we see is something that looks like lichen nitidus. That is very small, pinpoint, discrete, hypopigmented, or sometimes erythematous papules. And this looks like either lichen nitidus, or if there is some photo exacerbation which can happen in AD, you may think that is the pinpoint papilla type of PMLE. And but we are usually able to make a diagnosis because one, it is common in India, and that there's a background of cirrhosis, there is pruritus, other atopic markers, the remitting relapsing history and all that, and response to the emollients and all that. So this is a common version of AD that we see. And as Rashmi was talking about the severity measures, these types of AD don't have much oozing, they don't have papillation, but they can have significant amount of pruritus. So the subjective measures are quite high. That is why we just don't stick to the objective measures. You need different domains where we look at the outcomes when we are looking at response to treatment. So if you just look at the patient, it looks mild, but they may often have severe cirrhosis and pruritus, which comes under maybe the POEM score, as ma'am mentioned. So the second type is a follicular AD. Again, this is the most common type we see in infants and young children. Plenty of dryness, often pruritus, no florid eczema, lichenification, but you see follicular accentuation in groups all over the body. And again, the subjective symptoms may be quite prominent even to classify, enough to classify it as severe AD in many cases. So this is technically atypical, but that is very common forms in India. So the few things about infants and young children. One is that atopic dermatitis can significantly overlap with seborrheic dermatitis. So one consistent observation in many studies is that very young infants, like under 3 months and all, even cradle cap is common in everybody, but some of the infants do get significant amount of seborrheic dermatitis, which extension beyond the scalp, other flexural areas and all. So it was observed when these kids are followed up that those kids who did not have a diagnosis of seborrheic dermatitis in early life were less likely to get a diagnosis of AD later. So it basically meant that people with seborrheic dermatitis gradually shifted into an atopy-like pattern with cheek and extensor involvement, dryness, follicular accentuation, and all that. And somewhere at 6 months to 1 year, this seborrheic pattern disappeared and it shifted into a totally atopic pattern. And in between, it was sort of overlapping. So this is not at all unusual. We commonly see this in clinics. And so basically the hypothesis is that infantile seborrheic dermatitis is probably not a distinct entity. It is probably the same as atopic dermatitis. It's just a different morphology, probably connected to the endocrine milieu in early infancy. So basically you can treat this as seborrheic dermatitis itself. So the another thing which we see in infants and young children is the atopic dermatitis psoriasis overlap. So this is, again, if you're quite careful, you can see it in plenty in India. And even this is in worldwide literature, this is actually most prominently reported in Asian AD and as well as South Asian countries like India. So Here you can have picture that is quite confusing. It may look a little like psoriasis. It may look a little like eczema. So there may be very well-defined lesions which are more scaly than oozy. But when you're thinking of psoriasis, it is not having that florid, dry, silvery scales, and the plaques are quite thin. And we already know that psoriasis in children, the plaques are thin. It is much more pruritic than psoriasis in adults. The scaling is less, and it can often look like eczema. So eczema can have some psoriasis-like features with well-defined plaques, which we are often confused whether it's nummular eczema or psoriasis. We struggle to fit into either. And in each visit, sometimes it can look like psoriasis, sometimes it can look like eczema. So there are different patterns. Sometimes it may coexist, sometimes it may alternate. So, and many times the type of coexistent psoriasis which we see is sebopsoriasis pattern. And there is a hype from this, it was found that in such cases with significant skin thickening and well-defined plaques, the cytokine milieu was rich with interleukin 17 and 22. And this is actually a quite common feature that is seen in Asian AD. So again, just like we had an overlap between seborrheic dermatitis and atopic dermatitis, in children, we have an overlap with psoriasis as well, probably pointing to a common pathogenesis. So this is just a typical case that we see. It's an 8-month-old infant who, in the trunk, if you look at the image on the right side, you can see extensive follicular papules which are in grouped fashion. There is subtle erythema. There is also hypopigmentation as well, and there is significant amount of dryness and pruritus. So usually, though AD spares the diaper area, if you look at the pubic area, you can see that there is a sharply demarcated area of erythema. It is actually an irritant diaper dermatitis. It was sparing the deeper folds and it was quite demarcated. And due to the immature barrier, these atopic kids are actually more prone to diaper dermatitis. So that is just to remind you of one of the atypical manifestations. And in the retroauricular area, we can see a sharply demarcated fissured scaly plaque. Again, retroauricular area is not typical for AD in this age group, but there is an overlap with seborrheic dermatitis or perhaps even psoriasis. So again, this retroauricular fissuring is a common thing which we see in moderate to severe AD in infants and probably indicates an overlap. So this is the same kid. The kid has been having very sharply demarcated nummular plaques over the dorsum of the forearm and the dorsum of the hand. Again, does not indicate that this is not AD. It again just shows you that there can be well-defined plaques which look like psoriasis, and there is a significant overlap in the morphology, especially in the younger age groups. And when kids start to crawl, we get well-defined lichenified plaques over the shin as well. Even that was there in this child, but not included in the photos. So next, I'll just briefly mention about hand eczema in atopic kids. So atopic hand eczema, we usually suspect when we have symmetry, when we have dorsum involvement, and it is extending all the way to the wrist. These are quite important clues which indicate that the hand eczema is endogenous. And adults exogenous hand eczema, we have a lot of information, but hand eczema is also relatively common in children. And there are not many studies, but the existing studies indicate that if children have symmetrical hand eczema, atopic kids, contact allergens is probably not that important. But in clinics, we can often see children who have more involvement of the dominant hand, the fingertip eczema and all that. So probably we need more studies to look into their allergens which they encounter in school or during hobbies. So then there are other types of hand eczema, which is symmetrical hand eczema that can occur in children with atopy. One is pemphigus, and the other is hyperkeratotic eczema, which is more common on the feet, fingertip eczemas, and the hand version of juvenile plantar dermatosis. And intervention-wise, in addition to atopic precautions in pemphigus, if it is difficult to control, we also need to look into whether it's a systemic contact dermatitis to nickel. Sometimes having a nickel-free diet, especially if the past test is positive to nickel, does help in management of pemphigus, which is again an AD-associated hand eczema. So this is just an image that shows a few eczema of the feet. In the forefoot, we can see a shiny glazed appearance over the toes, and there is scaling and fissuring. And this is the other images from another patient, where over the dorsum, we can see extension over the dorsum plus a pattern dermatitis. So in the hand, we mentioned dorsum involvement is more suggestive of endogenous. In the feet, it is exactly opposite. So involvement of the dorsum, involvement of when we see a pattern dermatitis, which indicates the straps of a footwear, we usually think allergic contact dermatitis. So that's a general dictum. So if we see something of a forefoot eczema, which looks like juvenile plantar dermatosis symmetrical, we think endogenous, and dorsum, we think exogenous. So this is a first, I think, of a few interesting studies which looked at patch testing in children with feet eczema. And these kids initially had different clinical diagnoses. Most of them were diagnosed with endogenous atopic eczema. Some of them were clinically diagnosed with contact dermatitis because of pattern dermatitis. But when patch testing was done with the Indian Standard series and also with footwear series, it was found that those with juvenile plantar dermatosis had, in 53% of the cases, a significant patch test positivity. And they went back and looked at the clinical scenario, whether it was having some clinical significance, whether a particular footwear correlated with exacerbation, whether withdrawing that particular allergen led to improvement. It was mostly found clinically significant. So the take-home point is that in foot eczema in children, even if it looks properly endogenous, and especially if you find it difficult to control, always think that allergens may be playing a crucial role. And I think a study from Puducherry found dispersed dyes and rubber allergens, and a study from Thrissur Medical College actually found dispersed dyes. So mostly it is a rubber footwear that they use at home, especially those brightly colored like black rubber and those with azo dyes like orange, red, yellow, blue even. Those were the ones that actually, when withdrawn, had resulted in a significant clinical improvement. So we'll just go through a few more exogenous allergens which are important in atopic kids. It's a thread dermatitis. Most of us would have seen in atopic kids, they have overt eczema or just hypopigmentation, which is more prominent over the hips. So the sacred thread is tied around the waistline. This is more common, I think, in other states. We usually have metal jewelry. So, but even then, if there is a thread there, especially black, red, blue, or even yellow, this can cause a local dermatitis. And sometimes it may be just hypopigmentation. And interesting thing is that these threads have been found to contain azo dyes, which are actually banned dyes because they are potential carcinogens. So we may have other than allergy, we may have another point for asking for these threads to be removed. So another thing which we commonly see in atopic kids is toilet seat dermatitis. And usually we can see the ring of the toilet seat itself, like 2 arcs over the buttocks and 2 arcs of the posterior thigh. So this may be isolated if in children with mild disease, and those who are already having florid AD elsewhere, this may be one spot that is difficult to treat because we are not identifying the trigger. So it can be an allergic contact dermatitis, and sometimes it has an irritant picture also. And reviewing literature, the allergens implicated are polyurethane in plastic and also various harsh cleansers. So depending upon whether it looks allergic or looks irritant, we can take appropriate measures, and not only avoiding the seat, actually the cleansers which are used to clean the toilet seat and the ceramic bowl, which may later come into contact with the kids' buttocks, should be considered. So this is all about morphology, age of onset, and any atypical triggers. Few more unusual triggers. So I think postgraduates are kind of aware that when you have a child with atopy and we ask for trigger avoidance, we are thinking about food allergens only in generally young kids. And we have a set of food allergens which we commonly suspect, that is milk, egg, soy, nuts, and wheat. And they are more significant when you have severe AD and poorly controlled AD, and we don't even investigate until the child is young and the AD is not well controlled. And older children, food is thought to be not that important, and they are more important is the aero allergens and the contact allergens which you just mentioned. But when we have, this is like what is typical, but when the disease is poorly controlled, and very often the parents are giving a very clear history that certain foods are triggering the disease and avoidance is improving, we do have to consider dietary allergens, even though the children are older. So this is not commonly encountered, but we do see this in children who have moderate to severe disease and who are poor control. And reviewing the literature in India found that one study had reported that these kids, older kids like 5 to 10 years, had significant IgE and prick test positivity to some fruits like apple and nuts. But then I think from a personal experience, what I found is that I have not been able to do prick test, but serum IgE has been found elevated to many dietary agents which are quite important in the South Indian diet. So I definitely think probably more studies are required to investigate what other allergens other than the commonly implicated ones. So importance, coconut is one of the commonly implicated ones, with the withdrawal of which has found significant impact in few children. And the importance is that we, in addition to the fact that coconut is there in almost all of our dishes, coconut oil is freely prescribed by everybody for in atopy, and that itself can actually trigger AD in these kids. So this is just a pointer note that the triggers may be unusual in addition to the morphology and the age of onset. So this is just a summary of how AD can be atypical and it can fool us. We may miss AD because it has not been there for a long time, but remember that it can be adult onset and senile onset, and these conditions are being characterized as we go along. And the site can be atypical. It can be localized to particular sites, but watching for the atopic markers, watching for the personal history and family history of AD can help you make a diagnosis. Morphology can also be atypical, but many of the things which are described as atypical and not having a florid eczema are actually the common ones in our pigmented skin. And then the triggers can be unusual. There are many contact allergens which are important. So when you're treating AD and your barrier precautions are great, your treatment is fine, and there are some clinical clues, always look at contact allergens and perhaps even food allergens in older children. So that's it for my presentation. I'd like to thank the audience as well as Crichton sir and East West Pharma for giving me this opportunity. And there's a lot of lacunae, especially in the triggers in children. And I'm sure Crichton sir and Rashmi ma'am would have a lot of valuable experience to offer where we don't have evidence.
Thank you, Dr. Irene. It's a wonderful talk again. I was just hearing both of your presentation. I really have a good faith in the future of dermatology. Both the youngsters did very well, and congratulations, Dr. Irene and Dr. Rashmi, for your wonderful presentations. I'm sure that you will do some good work in atopic dermatitis, and I think this should be a platform for you to collaborate and do further research. And as you said, you can have, I mean, a lot of knowledge gaps in atopic dermatitis. I have my own impression that atopic dermatitis is not a single entity, and it is genetically, phenotypically, and otherwise is a distinct a group of diseases. So we can have some sort of, and the postgraduates should have this in mind, and you can have further when you choose thesis topic or projects of your own, that you can choose one of these areas, knowledge gap areas, and do something for the betterment of the treatment of atopic dermatitis, or scoring of atopic dermatitis and whatnot. So thank you very much for the wonderful talk given by Dr. Rashmi and Dr. Irene. And I think we will have some more sessions of this sort at a later date. Thank you very much. Thank you.